Medicine is actually an art, and art is meant to be enjoyed. Often I see a lot of memes and a lot of patient notes circulating on social media about how a clinician took a bad history, about how a clinician made an impossible diagnosis. By impossible, I mean a ridiculous diagnosis. And many people underappreciate the value of taking a good history, which is why I decided to put this video together. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at the pediatric history. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to receive notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So this all stems way back when doctors used to take history in a very haphazard manner. It wasn't really correlating until one guy who was actually not even a doctor came up with a way in which you can actually ask these questions, a format or a template per se. And that's how we got to learn how to take history in a proper systematic way. So all good doctors actually know that history taking is a very important skill because 90% of the times the answer is in the history. So which is why you need to hone and improve your skills on history taking. Now, the biggest challenge that you will potentially face if you have never taken history in pediatrics, or if you're in pediatrics for the very first time, is that not all your clients will be able to talk to you or talk back. Some of them will be too young to understand or even tell you the problem. So usually, most often you have to depend on the parents for the history, and often parents are not really 100% truthful because they're parents. Sometimes they do lie here and there, and you have to take everything with a pinch of salt. Never trust anyone anyways. So in this vein, you're going to need to be very observant, especially when you're taking the pediatric history, for certain non-verbal cues. Whenever you're interviewing the mother and you're looking at the mother, you're also looking at the child for these non-verbal cues that may actually point you towards certain diagnoses. So the first thing that you must always do before you do anything is always greet the child and the parent by their name. I often see what's hey, him, her, it. Do not use those. You do not use those things. Make sure you know the patient's name. Greet the child by the parents, or rather the patient's name, and greet the parents by their name. This will show like as if you have some concern and general interest. Introduce yourself, obviously, explain what you're about to do, and gain consent. Hi, my name is Moses Kazevu. I am a fifth-year medical student at Lusaka Epics Medical University, and I would like to take a history of your child. Is that okay with you? Then go ahead and take the history. So this way in which you actually introduce yourself and show some concern, it's going to lead the mother to open up easier to you. Even the child will be much more comfortable towards you. And remember that information that's taken in the history is usually going to be obtained from the mother, but you may sometimes even just get useful information from observing the infant doing certain things when you're taking the history. The older children must be given an opportunity to talk. So do not allow the mother or whoever is accompanying them to be saying everything. If they can talk and understand, get it from them. So a simple act of actually giving a toy, a picture book, or a pen torch to the child to play with actually helps you gain their trust and build their rapport. So what are some of the elements of the history taking? It's the basic thing. It's quite similar in almost all the courses. It's just that we add a little bit of the things to the backbone. So the first thing is demographics. Then we look at the presenting complaint, the history of presenting complaint, review of systems, past medical history, drug history, birth history both during pregnancy and delivery, immunization history, nutritional and feeding history, development and growth history, looking at the neonatal period, infancy, as well as subsequent developmental milestones, family history, socioeconomic history, then we have a summary, and we offer certain differential diagnosis. So I'll go into details of each of these components so that you understand what exactly you're going to be asking. So the first things first is demographics. So before you actually even start taking anything, observe the child whilst they are playing in the waiting area. Observe their appearance, observe the behavior, observe the gait as they walk into the clinic. All these things are clues towards the possible diagnosis that you're going to be having. So as you continue observing the child during the whole interview, you may get these important clues that may point you towards the diagnosis. There are certain types of conditions that present in specific ways that can cause a child to be walking in a specific way. Suppose a child comes in with a limp and features that are suggestive of sickle cell. Then you're thinking maybe this could be sickle cell. Maybe they have an osteomyelitis. So you're going to be the patient's name, the age, the gender, the region of residence where they stay. Of course, these, if you're already working, they would already be done by the people that work in the registry. Then the religion, the informant, who is giving you this information. Is it the parent or is it the patient? The date when you took the history and examination, and indicate whether this is a hospital referral or a clinic referral or a self-referral where they just came to the hospital and were not referred from any other health facility. If indeed they were referred from any other health facility, please state what they were referred for and why they were referred. So we start with the first thing, which is presenting complaints. I will also introduce a bit of some medical terminology which often confuses a lot of students, especially when you read through the notes and you think like as if it's gibberish and you don't understand what doctors are writing. So presenting complaints, you can either write PC or CO. CO just simply stands for complaining of. So here, these are the reasons why they're seeking medical care. And do not forget to add the duration of the symptoms. So here there is a bit of some debate. There are some people that say start with the most remote symptom. For example, the furthest symptom, listing them in order like that to the most recent. There are some that say start with the most recent, going to the furthest. So what prompted them the referral to the doctor? When was the onset of these symptoms? It's quite important. And if you are in doubt about the dates on the onset, then the patient should be actually asked when the last felt quite well and why they first consulted the doctor in the first place. Then when it comes to the duration of the symptoms, there is a notation that is used, a special type of notation. Remember, there are 7 days in a week, 52 months in a year, 52 weeks in a year, 52 months, 52 weeks in a year and 12 months in a year. So 1 out of 7 is going to be 1 day, 2 out of 52 will be 2 weeks, 1 out of 12 will be 1 month. I hope you now understand that notation that is being used in the files. And what do the parents think or fear the problem is? Remember, record the presenting complaint always in the patient's words. Do not interpret them into medical terminology unless if they use medical terminology, then you can put that word in inverted commas, like for example, giddiness, wind, palpitations, and you should actually make an attempt to see if the patient actually correctly understand what they are referring to. So ask them to explain. So here's an example of how it can be in list format. So diarrhea for 2 days, joint weakness for 1 day, vomiting for 1 day. Already this is giving you a picture that you can actually build upon when you're taking the history. Then we come to the history of presenting complaints. History can also be abbreviated as HX. So whenever you see HX is history, then PC is presenting complaints. And then when you see PT, it means patient. So this is obviously like a story that's going to be linking now the clinical features or the presenting complaint, how this person progressed from the last time they were okay through the illness. So this will give you now a storyline of how the symptoms are actually building up and how this patient is progressing. So this is what actually is going to help you even focus your mind on the specific diagnosis. There are specific questions that you can actually target based on the system. Usually a trick that I like to use, if I get back to this slide here, a trick that I like to use is that I focus on the presenting complaints and ask myself what systems are involved. If we're talking about diarrhea, so it's going to be the GIT. So I should ask questions in relation to the GIT. If you talk about vomiting, it's also relation to the GIT. So I should ask questions based on the GIT. If I look about joint weakness, this is the musculoskeletal system and possibly the skin. So I should ask questions based on that. So those are the things that I'm going to be building upon in the review of systems. And I'll come to the exact questions that you should ask. I'll give you a list of them. And here there's a very, very big disclaimer. There are certain things that you can't ask certain aged children. For example, how are you going to know that a child that is 2 months that can't talk has a headache? Of course, if there are no signs of intracranial pressure, how are you going to tell that the child has a headache? It's almost quite impossible. So there's some questions that you would even just use your mind, as in, even if I was a parent, how would I know that my child has this? How would you, as a doctor, know that the person has this subjectively speaking? It's quite impossible to do. So here we usually avoid using days of the week because they do not indicate the duration of the disease. So let's say the patient was well until last Wednesday. No, maybe use actual figures like 2 days ago, 3 days ago, 2 weeks ago, so on and so forth. So here you're going to be describing the course of the patient's illness, when it began, how it began, the character of the symptoms, any aggravating or alleviating factors, any pertinent positives, negatives, any past diagnostic testing that was done in this patient. So you should let the parent actually give a history in their own way, then you should guide them with specific questions. So you should ask how severe the symptoms are. Have they changed during the past days, weeks, months? Has there been any recent change in the child's appetite? Because usually when children are sick, the first thing that you're going to be noticing is that they won't be playing as much and they won't be eating as much. Ask also about the energy and the activities of the child. Have they been absent from school? Is there anyone who takes care of the child who has been ill? And is the child thriving, or are they losing weight? Is there any change in their behavior or changes in micturition or bowel habits? So usually here we're going to be expanding on the presenting complaints. For example, if someone presented with GI symptoms like in the previous slide, we're going to be going and asking the questions that are in relation to the GIT. Then the other systems that are not there, because sometimes patients come into the hospital thinking that one thing may not be connected to the other. For example, if someone has, let's say, a headache, then they don't think that the rash is connected. They may not mention the rash because the headache is the most significant thing. But then when you come to the musculoskeletal and skin area, then you ask them if they have a rash, then they remember that, oh, by the way, I actually had a rash. So this is why it's important to actually review the systems to make sure that you haven't missed anything else that the patient may not think may be related to the illness in some way, or they may have overlooked these symptoms. So I like to use a head-to-toe approach. For everything that I do in medicine, there should be some sort of systematic order. This way to help you remember all these concepts. So I like to use a head-to-toe approach. So coming from the CNS, the CVS, the respiratory system, the GIT, the GUT, the musculoskeletal system, and the skin. So remember that some questions can be asked to the very young children as they can't talk, and the mother cannot really justify if the child has experienced the symptoms. For example, if they're dizzy, how is a 2-year-old going to, actually 2-year-olds, maybe they can speak and vocalize, but a 2-month-old, how are you going to know that the child is dizzy? And do 2-month-old children, my God, do 2-month-old children actually get dizzy? Okay, so we'll start with the central nervous system. So there's loss of consciousness. This can actually be seen by the witness. So sudden, was it sudden? Was there a warning? Were there any injuries? Were they passing urine? The duration, and what did they do after? What were they doing before? Any precipitating factors, any witnesses? So remember, if you find that this is positive, make sure that you expand a little bit about it. Ask for further details. Is there any dizziness or vertigo, which you can only ask in older children? Any numbness, which also you can ask in older children? Seizures can actually be subjectively seen. They can be seen by the mother. They can be seen by the caregivers. So there are certain features. Remember, the seizures in children are rather subtle. So it may be like a blank stare on the child. They may sometimes make these chewing movements. They may sometimes make these boxing or even cycling movements. Then headaches and behavioral changes. Behavioral changes you can assess in a younger child, but in a younger child, headaches will be very difficult for you to assess. Then visual disturbances, this is only for those that can actually talk. So if they're seeing double, which is diplopia, dimness, zigzag figures, which is fortification, spectra, then dizziness or tinnitus, is there any discharge from the ears? Is there any pain in the ears, or is there any hearing loss? Then of course, speech disturbances, the duration, the onset, the nature, the problems in reading or understanding. Then we also We also look at the memory, or assess the memory. So this should be independent opinion of the relative or friend. You should search this out. Have they been having any memory lapses? Of course, you can't do this in a very, very young child. So as you can see, there are some questions that you can ask, and some questions that you already know that you can ask, because how is the mother going to quantify that? How are you going to quantify that? Then we come to the respiratory system. Cough can be actually seen. What's the character? What's the frequency? What's the duration? Is there any pain? What's the timing? Is there any sputum that's being produced? If there is sputum, what's the color? Is there any blood that is there? And what's the quantity? What's the nature? Is it frothy? Is it stringy? Is it sticky? What's the odor? What's the timing? When is it most profuse? Is there any blood, which is hemoptysis? Is the blood red, which is known as frank blood? Or is it brown, which is digested? Or it's just streaks or speaks of blood? Is there any dyspnea, which is difficulty in breathing, at rest, during exertion? For example, a child runs a bit and then they squat. This could be pointing towards a congenital heart disease. Are there any precipitating factors? For example, coughing, the emotions, change in environment, even is there any wheezing? Is there any pain in the chest? And remember, whenever you have pain, don't forget your Socrates: site, onset, character, radiation, alleviating factors, timing course or timing onset, exacerbating factors, and associated symptoms. Then ask for the location of the pain, the character, if it's affecting respiration, the position that increases or decreases the pain. Is there any hoarseness of the voice, with or without pain? This may be meaning that there's some involvement of the recurrent laryngeal nerve. Any sore throat, because tonsillitis is very common, infections are very common. Any ulcerations in the mouth, any nasal discharge or features of nasal obstruction, such as a noisy breathing, especially when the child is sleeping. Any nose bleeding, which is epistaxis, night sweats, wheezing, which may be pointing towards asthma, chest infections, relieving factors, COPDs. These are also dependent on the age of the individual. Then the cardiovascular system, again, if there is dyspnea, remember dyspnea could be related to the respiratory system or it could be related to the cardiovascular system. Is it on exertion? What's the degree? For example, the child just walks and they are breathless. What's the time that dyspnea comes on? Is it at night, such that the patient is actually even unable to lay down flat? You call this as orthopnea. What relieves the dyspnea? Is there any gradual or sudden onset? Is there any change in duration? For example, is there any paroxysmal nocturnal dyspnea where they wake up at night feeling breathless or to catch a breath? What are the precipitating factors? What's the number of pillows that they use? Then, of course, the chest pain is just like with the respiratory system. So pretty much the site, the onset, the character, the radiation, the duration, the alleviating, exacerbating, associated symptoms. Do they have any palpitations, which could also be a very difficult thing to ask a child that's very young? Dizziness or any fainting episodes, because this could also be CVS, but I've already asked this in the CNS, so it's not really so important to ask at this stage because you would have already asked. But anyways, you have to be thorough. Have they noticed any swelling of the ankles during the time of the day? Any pain in the calf muscles, especially when they walk? You call this as intermittent claudication. Coldness of the feet, which may point towards Raynaud's phenomenon. Then we come to the GIT. Do they have any abdominal pain or discomfort? What's the site? What's the character? Is it constant? Is it colicky? What's the radiation? Is there any relationship to the food or bowel actions? Are they having any nausea and vomiting? What's the frequency and the relationship to food? What's the amount of vomitus? What's the content? What's the color? Is there any blood in the vomitus, which is known as hematemesis? What's the appetite? Is there any loss of appetite in this child? Are they having difficulty swallowing? Is it difficulty swallowing with hard foods or solids? Is it difficulty swallowing with liquids? Or is it a progression from solid foods to liquid foods, having difficulty swallowing? And at what level do they perceive the food to be sticking at, quote unquote? Do they have any diarrhea? What's the frequency and the looseness of the bowel movements? Do they have any constipation? Is it recent or is it long-standing? And what's the severity? What's the nature of the stool? Do they have any black tarry-like stool, which is known as melena, which is usually a feature of upper GI bleeding? Is there clay or pale-like stool, which may point towards obstructive jaundice? Is it bulky and fatty, which may be leading towards steatorrhea, which is also seen in obstructive jaundice. Then, of course, is any blood, which may be indicative of piles, frank blood. Then tenesmus, which is a painful sensation and an urgent need to defecate. This may indicate a rectal pathology, or do they have any flatulence? Then in the GUT, micturition, how often are they urinating? Is there any frequency, retention, dribbling? What's the amount of urine that is passed? How many times has the mother changed the diaper? Is there any incontinence? Then what's the urine color, the amount, the smell, any blood? Is it frothy? Are they having any difficulties in passing urine or flank pain? Of course, these are only questions that you can ask a much older child and not really a young baby. Then, of course, if the child has attained menarche, ask them about the history of menstruation, the age of onset of the menses, that's known as menarche, the last normal menstrual period, the regularity of the cycle. Obviously, most children that usually get into menarche usually have irregular cycles in the first few cycles, then it becomes regular afterwards. Then the number of days or intervals, the amount of blood that is lost, is there an increase or a decrease in the flow, any discharge in between, and of course if they have any vaginal discharge, the quantity, the color, and any smell or any irritation. Then we come to the musculoskeletal in the skin. Is there any joint swelling, any joint stiffness, any skin rash, the type, the duration, any treatment that was given? Is it painful? Is it itchy? It could be psoriasis. So that's the review of system, and those are the questions that you will be focusing on. If you haven't yet stated them in your history of presenting complaint, then you have to focus on them in the review of system. Now, suppose you got a patient that had GIT symptoms and you covered the GIT in the history of presenting symptoms. So it means you do not have to repeat the GIT in the review of systems. Of course, some individuals say that you do for the purpose of thoroughness, but others, generally in the bulk majority, say that you shouldn't actually repeat the same things. Then the past medical history is the next segment, where now we ask this patient, have they had any similar illness in the past? Have they had any other medical problems? Have they been hospitalized before? Is there been any prior admissions? If there have been any prior admissions, what were they admitted for? Because this could be an indication that it's a chronic illness. What was given to them? How was the treatment given to them? Then is there any operations or any accidents or injuries that happened? So you can say past medical stroke surgical history. Then you ask for certain chronic conditions. Diabetes, of course, you also have to think in your head. There are certain conditions that you can diagnose at certain ages. For example, someone is 1 month and you make a diagnosis of asthma and you say that there's a history of asthma. That already doesn't make sense. So you should usually use your mental capacity to think through these conditions first before you even ask a 2-day-old baby if there's a history of diabetes in them. Okay? So ask for diabetes, epilepsy, asthma, TB, HIV, sometimes even hypertension, sickle cell disease. So you can remember the mnemonic deaths. Then any history of any pediatric deaths, inquire about the cause of death, and inquire if this child has received any past blood transfusions. Then the drug history, ask for any allergies to drugs, any allergies to foods. Ask the past and the current medication that the child is taking, the dosage, the name, and the frequency of which this medication is being taken. If ideally, you should actually have a look at the packaging or the drug to see what it is if they don't know what it is. Then we come to the birth history. So I like to divide this into 3 segments. What happened before the child was born, what happened during when the child was born, and what happened after the child was born. So the prenatal history, how was the pregnancy diagnosed in the first place? Was it by a urine Gravidex test? Was it by a scan? Did the mother have any obstetric problems? Did they have any prolonged rupture of membranes, any maternal pyrexia during the pregnancy? Did they make all the visits to antenatal? And if they did they receive the usual medications, the prophylaxis for malaria, that's the Fansidar? Then of course, if the mother is exposed or HIV positive, did they receive Septrin? Then was the baby born at term? And was it preterm? Was it term? Was it a post-term pregnancy? What was the mode of delivery? So when we come now to the perinatal history, or you can say intrapartum history, what is the mode of delivery? Was it a spontaneous vertex delivery or vaginal delivery? Was it an assisted delivery with forceps or a vacuum? Was there a C-section? What was the birth weight? What was the APGAR score? I once clerked a mother who actually was really, really brilliant. She actually even remembered the APGAR score of her child. Then, are there any birth complications like infections, jaundice? Was the child admitted during this period? Then in the post Natal history, how long did they stay in the hospital before being discharged, and what was the method of feeding this child? When did the child start feeding? Another important thing to ask about the birth history is if this child actually cried at birth. Then we come now to the immunization history. So the next 3 segments you can actually, or 4 segments, you can remember the mnemonic BIND. B for birth history, I for immunization history, N for nutritional history, and D for developmental and growth history. So when it comes to immunization history, are they under 5 up to date? The many different immunizations that are actually there, I will leave a card tagged at the end of this video such that you can check out the immunization of the under 5. I did a video on that. So is the immunization up to date? Then if it's not, ask them why. Document which vaccines this child has received and which vaccines hasn't received. Of course, this should be age appropriate. Then what's the nutritional history? What's the type of the diet, the amount of food that is taken in each feed? Are they changing any feeding habits? Are they breastfeeding? What's the duration of which they breastfed? When did they wean off? Of course, this also has to use some sort of thinking. You can't get a 16-year-old and you ask them, when did you wean off from breastfeeding? It doesn't really make so much sense. Then we come to the developmental and growth history. Now, if you know how milestones actually work like, this becomes very easy. Because you know that once a child has attained a certain age, if a child is able to walk, you are already assured that this child can sit without support, they can crawl, and they can cruise. Then if they're able to stand, you're already rest assured that they can actually sit without support, because the milestones actually work in a progressive manner. So there are certain age appropriate milestones, like for example, head support, sitting, standing, walking, talking, self-care, and even smiling. What's the relationship with the siblings and the peers and adults? What school do they go to? How is the performance at school? If they are at school, are there any behavioral problems? And then you look at the growth curves. That's the under 5. Have they been gaining weight? Have they been losing weight? Or the weight has been consistent? Then we come to the family history. So are the parents alive? Are the siblings alive? What are their ages? Is there any medical history in the family of diabetes, epilepsy, asthma, TB, hypertension, and sickle cell? So remember deaths again. Then what's the socio-economic history, which I think should be the last thing? What's the family situation? Where do they stay? Is it a well-ventilated place? What's their water source? Is it an indoor toilet or an outdoor toilet? What's the relationship with the caregivers or the parents? Do the parents work? What's the level of education? Because all these things do matter in pediatrics, because the caregiver is a big influence to the health of the child. Then, of course, for alcohol and smoking, this is, of course, in adolescent pediatric patients and not really the young children, because you can't ask a 2-year-old, is there any history of alcohol or smoking? They'll pretty much laugh at you. But you can ask, of course, a history of alcohol and smoking in the case of the parents. Then is there a history of them traveling recently, particularly to a tropical area, that may actually explain the child's symptoms? For example, if they move to a malaria endemic area. Then after you do this, you give us a short and brief summary that's going to be highlighting the important positives and negatives. After you give now your brief summary, you should practice this as much as possible. If you really want to walk through to a clinical case that I clerked, just please comment in the section below and we'll do a clinical walkthrough in a case and how to present a case in pediatrics. Then we give a differential diagnosis, so we list them in order from most likely to least likely, relating them to your history. So do this actually when you learn how to take a history for the first time, because this will help you now build your clinical database and build your clinical skills. Someone once said that a good summary is like a miniskirt. It is short, brief, yet covers all the essential parts. I really hope you enjoyed this video. If you did, consider subscribing to the channel. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.